Okay, thank you very much, Tammy, for introduction. It's great to see everybody here. I want to add one addendum to what Ferg just said, which is that Alan So actually won the very first Bladder Cancer Canada Research Award for his bladder cancer research. But anyway, it's great to see everybody here. I've been back in Vancouver since 2008, so just a year before Bladder Cancer Canada was born, and it's amazing to see the growth, and it's so important for patient support. I think we as physicians don't get very far in the support part, so it's great to have that. So I'm going to jump right into non-muscle invasive bladder cancer, and Alan's going to talk about muscle invasive disease. I'm going to focus mainly on management. I'm not going to tell you very much about risk factors, background, any of that stuff. We're just going to get right into it. So I'm going to tell a little bit about what it is. Then I'm going to focus on the first resection, so the transurethral resection of the bladder tumor, TURBT, and then treatment and how we base it on risk, so how we define risk, and then how we treat based on risk. And then we'll talk a little bit about BCG and what happens after BCG. BCG is such a focus of care for many patients. So what is non-muscle invasive bladder cancer? I'm going to abbreviate this, NMIBC. You'll see that on the slides, but that's non-muscle invasive, and muscle invasive is without the N, so it's MIBC. So we have the whole spectrum here from the left to the right of cancer cells just in the surface, which we call CIS, or on the slide it's CIS, but that's carcinoma in situ, all the way to a big invasive tumor on the right side that might be spreading to an adjacent organ. The key distinguisher in how we treat these patients is the muscle layer, which you can see in this sort of peach color, I guess it is. So here we have a tumor that's growing into muscle, and these ones are not, hence the name non-muscle invasive. And the treatments are quite different, and Alan will talk about the chemotherapy, surgery, radiation, but I'm going to talk about how we preserve the bladder and the treatments we put into the bladder to do so. It's important to highlight just that each one of these represents a little bit of a different entity here. So the carcinoma in situ, which I'll show on the next slide, versus this is also the TA tumors are limited to just the surface layer of the bladder, but they form an actual tumor, which these ones don't. This is the classic sort of sea anemone looking bladder tumor. And then the T1s are on the verge of becoming muscle invasive. They invade into this first layer, the lamina propria. And we think of them as having the potential to turn into muscle invasive tumors if left long enough, whereas a lot of the lower stage ones wouldn't necessarily do so. So what is carcinoma in situ? I think a very confusing entity for patients who are dealing with it. The in situ implies that it's still in its anatomic location, it hasn't spread anywhere, but what it really means is that it's cancer cells that are confined just to the very surface of the bladder. So this is what we call the basement membrane, and the cells are right where they're supposed to be, but they're highly malignant. And we treat it as if it is a highly malignant cancer, and if we can't get rid of it, we'll remove the bladder to prevent it from turning into something worse, which it will do over time. And unfortunately, it's typically a fairly diffuse thing, so it can be anywhere in the bladder. It's not just one spot. So it's not like we can just go in and scrape it away and remove it surgically. So let's focus a little bit on the initial resection, the TURBT. This is the beginning of the treatment journey, maybe not the overall journey, but the treatment journey for most patients. If a patient has a bladder tumor or something suspicious, we need to go in and get some tissue to confirm the diagnosis and decide what to do. And this is a picture that sort of shows how we do it. It's an electric wire with current flowing through it, and we can cut a tumor out, usually in pieces, so sort of a piecemeal resection. And there are a few new things going on with TURBTs, and there are also some just additional elements to think about when you have it. I'm just going to talk a little bit about en-bloc TURBT, which is a new concept, not necessarily done widely, but it's a new concept that we're talking about. Blue cystoscopy, which is the fluorescent cystoscopy, and talk about the single dose of chemo that we put in the bladder after resection. So en-bloc TURBT, so I said that we usually now resect tumors in pieces. There aren't too many other cancers where we actually cut it into little pieces and let the pieces float around before taking them out. So it's a bit of an unusual approach for removing a cancer. Usually we want to remove everything in one nice piece. And this is what we give the pathologist, a bunch of little fragments, and the pathologist has to tell us exactly what's going on. So there's a bit of a movement in the field towards what we call en-bloc resection, where you actually try and get under the tumor and lift the whole tumor off in one piece. This works for relatively small, confined tumors. And you can see here that what we send the pathologist then is one tumor, the whole tumor in one piece, and the pathologist can actually look at margins and give us a better interpretation of what's there. It's thought to be safer. It could conceivably have a lower risk of recurrence because we're not cutting it into little pieces that spread around the bladder, although that has yet to be shown. And so this is something that I would say is just starting. Don't necessarily go to your urologist and say, I want the en-bloc procedure, because it's not there yet, but a lot of people are starting to do it. The blue light cystoscopy is done in addition to surgery. So this is not something that we can do in the office when we're just doing a routine cystoscopy for follow-up or for diagnosis. It's something that we do in the operating room when you already have a reason to be in the operating room. We put a substance in the bladder, which goes by the trade name Cysview, and it sits in the bladder for an hour before surgery. It's taken up preferentially by tumor cells, and it's actually metabolized into something that is fluorescent. And if we, in the operating room, then use a blue light, so a fluorescent light, we will see these pink patches or pink tumors. So it helps us detect tumors better. If we can detect them better, we can make a more accurate diagnosis and also do a better job of getting rid of tumors. And there is evidence of a reduced risk of recurrence if we use the blue light. So this is a technology that many European countries have been using for more than 10 years. In the U.S., it's been around for about 5 years. In Canada, just for the last couple of years, places are starting to adopt it. Of course, for us in Canada, there are always financial hurdles for introducing anything new. But I think this does add something to care. So we detect better and we reduce the risk of recurrence simply by better surgical technique. So what about single-dose chemotherapy? So this is a very common addition to especially the first resection of a bladder tumor. The idea is that if you put a dose of chemotherapy in the bladder after resection, it's going to get rid of any free-floating cancer cells before they seed somewhere. And it may actually get rid of small tumors that we don't see. So if we can't see something, we can't get rid of it, but chemo might actually get rid of it. How is it given? So at the end of the surgical procedure, the urologist will put a catheter in the bladder, put the drug in the bladder, the catheter stays in, it's all drained out an hour later, and then whenever the patient's ready to go home, they go home. So it doesn't add very much. It's done in the recovery room. And it reduces the risk of recurrence by about 1/3. So it's very, very significant reduction in risk of recurrence with a very simple maneuver. And so this is something I would encourage you to go and ask your urologist about and say, hey, can I have that? Or not can I have that, but would that be appropriate for me? It's not appropriate for all patients, so you need to be aware of that. But it's certainly a standard of care in a lot of patients on the lower end of the risk spectrum, which I think I'll show in the next slide. Side effects, there are different drugs that you can use, but there's a very recent trial using a drug called gemcitabine. And in the trial of a few hundred patients, you could barely detect a difference between saline and gemcitabine. So it's very well tolerated with few side effects. So who benefits the most? Well, it's not necessarily what you would think. It's not the patients who've had a bunch of tumors, a bunch of recurrences. It's certainly not high-grade tumors. It's often the first small, low-grade tumor, maybe an infrequent recurrence, but it's on the early end of the disease spectrum where patients benefit the most. So how do we define risk? So once we have the TURBT, the histologic sample, we then need to sit down and talk about, so what do we know about this cancer and how are we going to treat it moving forward? And when we're thinking of risk, we're thinking of risk of recurrence and risk of progression. Recurrence just means it comes back. Progression means it comes back at a higher stage, so it's growing deeper into the bladder wall. And of course, progression is what we worry about most. We want to prevent progression or remove the bladder before it has progressed is very important. So when we're looking at the TURBT specimen, we will first of all define the risk. So low-risk patients are those with their very first tumor. It's less than 3 centimeters. It's completely non-invasive, and it's low grade. And it's about half of patients, luckily. Half of patients are in the low-risk category. On the other end of the spectrum, and this again is all just the non-muscle invasive. If it's muscle invasive, it's a different conversation. But the high-risk patients are essentially any patient with a high-grade tumor. So the low-grade, high-grade is an important distinction, and it's a description of what the cancer cells look like under the microscope. So less aggressive, more aggressive. And then in between, of course, is always a mixed bag of everything else, which are typically the low-grade, non-invasive tumors that are or they're multiple. It's about 1/3 of patients. And each of these groups we will treat differently. So the low-risk patients typically just get the resection and the single dose of chemo, and then they are monitored. And if there's a small recurrence that is seen in the office at the time of cystoscopy, we can generally just touch that with some cautery and what we call fulguration and get rid of it in the office, and we don't need to go back to the operating room. So that's the low risk. The high risk is also relatively straightforward. Those are the patients who get BCG. So you'll know that BCG is a form of bacteria. It's a bovine tuberculosis, so cow tuberculosis, that we put into the bladder at regular intervals. And so all patients with high-risk disease should get that over 3 years, so induction and maintenance, so 27 doses over 3 years. We'll have to talk to Ferg to why he only got 18, but you're supposed to get 27. And in some patients, we'll actually remove the bladder. And in the middle, again, are the intermediate risk patients, and there's a mixed bag here again. They typically will have had their TURBT and single-dose chemo, but if they recur, then we will think about giving additional chemo, so after the fact, or BCG. Again, the BCG this time would be over 1 year, and the chemo also you would give over 1 year, chemo into the bladder. One of the things we do, which I'm sure seems a little bit funny to most, it seems funny to medical oncologists, never mind to patients, is that we'll often go back and re-resect tumors. So the high-risk patients, we will go back, we will bring you into the office or call you on the phone and say, okay, this is what it showed, and now we're going to go back and do it again, which seems a little bit funny. But we know that if we do a repeat TURBT in a patient who has invasion into the first layer, that we're going to find residual cancer in 1 of 3 cases, no matter how well we think we did it the first time. And it's important that we do that, because otherwise we're potentially understaging the disease, which will lead to under-treatment and potentially a bad outcome. So I mentioned that we should consider some patients for surgery up front, even if it's not muscle invasive, and I think this requires the urologist really to be informed and thinking about the risks. So if we have high-grade T1 tumors, so these are the ones invading into the first layer, and if you gave them enough time, they probably would become muscle invasive. So if you have multiple of those tumors or very large tumors, typically we want to remove the bladder and not risk BCG. T1 plus CIS, I'm going to skip through some of these because they're complicated, but if it's very extensively invasive, just a little bit invasive is a big difference. If there are different patterns of growth under the microscope that we call variant histology, these are additional risk factors that we might actually recommend removing the bladder even while it's non-muscle invasive. So intravesical therapy, I told you we can do either chemotherapy, which would be, you can see here, this is induction therapy, so we remove the tumor surgically, and then about a month later, we give weekly doses of chemotherapy through a catheter into the bladder, and then monthly doses up to a year. And for BCG, it's the same idea initially, weekly doses, but then the maintenance doses are at 3 months, 6 months, and every 6 months up to 3 years. And at each time point, you get 3 doses over 3 weeks. So it's fairly complicated, fairly intense, and fairly long. I typically see patients, at 3 months, and they're surprised that they get another one at 6 months. I see them at 6 months, they're surprised they get another one 6 months later, and so it goes. But I try to emphasize up front, it's a 3-year course. So now what if BCG doesn't work, and it typically does work fairly well? So we're always thinking about how can we replace BCG, or what can we add to BCG. We don't want to get rid of BCG. It actually works fairly well. We just want to improve upon it, and we want to have additional options. If we're giving BCG for intermediate risk patients, it's not overly threatening if the cancer comes back despite the BCG, and we would continue with other agents into the bladder, especially different chemotherapy agents. Typically, it would be unusual to remove a bladder for intermediate risk bladder cancer. Not unheard of, but unusual. For high-risk disease, if the BCG doesn't work, we are then talking about removing the bladder. And it's a difficult conversation because it's a very early cancer, but we really don't have good options to prevent it turning into something worse. And so we do, ultimately the guidelines recommend bladder removal. A lot of patients are not fit for surgery. You know, a lot of bladder cancer patients are older. It is a disease of the elderly. The rates go up rapidly as the population ages. And of course, it's a disease often associated with smoking, and a lot of elder smokers are particularly unhealthy. So a lot of patients are not fit for surgery. Some patients just don't want the major surgery of removing the bladder. We do have some options for putting treatments into the bladder, what we call salvage therapy. You can do more BCG, or you can do BCG plus interferon, for example, but they don't generally work very well. We're talking about a 20 to 30% likelihood of being free of bladder cancer 2 years after starting a salvage therapy. So if your only chances are 1 in 5 that you're actually going to be disease-free 2 years from now, and there's a risk of it turning into something different, it might be best just to take out the bladder. So the longer we wait, trying different things, the higher the risk that the cancer turns into something more invasive. But the quicker we pull the plug and remove the bladder, the higher the impact is on quality of life and the risk of complications. So it's really a bit of a tightrope that we walk together with our patients. The patients do most of the walking on the tightrope. So the guidelines say radical cystectomy. Most of us will give 1 round of salvage therapy to see if you know, the patient is going to be lucky and have a good response. And if it doesn't, then we're convinced that we need to remove the bladder. It's not an immediate risk of progression. It's a risk over time, and so we just don't want to waste too much time. Salvage options are various. We don't need to go into that. And I told you that this is one of the best studies that just looked at patients who have really, you know, the BCG, they've had maximum best BCG they can get, and it didn't work. And then they've gone on to get gemcitabine. Gemcitabine. Only 28% were free of cancer at a year, and 20% at 2 years. So it just doesn't work very well. But there are a lot of good things in development. There's one drug, this one down here on the left-hand side. They've actually changed the name now to Adstiladrin. Is going to be presented at a meeting in the first week of December. The deciding trial that will hopefully show that it really does work, and then it's likely to get FDA approval in the U.S. and Health Canada approval, and it will be potentially the first drug in a long time launched for intravesical therapy. The other ones as well, this Viventia is actually a Canadian drug. It's sort of a Trojan horse where the drug binds to something on the cancer cells and delivers a toxic payload into the cell that gets rid of the cells. So there are a lot of clever drugs in development. But just in conclusion, I think as patients start off on the journey with non-muscle invasive disease, the beginning is particularly important, where the TURBT and the surgical management is done carefully with all the additional tools that we have, including the blue light cysto and the intravesical chemotherapy. We then need to define risk of recurrence and progression and adapt the treatment according to that risk. And our biggest unmet need is the lack of options in patients who have recurred or progressed on BCG. But luckily, there are a lot of drugs in the pipeline, and I think that the future looks quite bright for patients with non-muscle invasive bladder cancer. So thank you.